In terms of antibiotics, dentists are responsible for 8% of all antibiotics prescribed in primary care. And thinking about that another way, that's 1 in 12 of all antibiotic prescriptions are prescribed by a dentist. There's actually very few clinical indications for using antibiotics in dentistry. For dental infections, the recommended course of treatment for most of these is drainage and then either tooth extraction or root canal treatment. And there's lots of evidence to show that dentists prescribe unnecessarily or inappropriately. Guidance to help support dentists was first published in 2008 by the Scottish Dental Clinical Effectiveness Programme. We're now on the 3rd edition in 2016, and there's also an app to support this. When this guidance first came out, it was antibiotic prescribing that was prioritised by stakeholders as a key area for implementation. And what we did at that time is that we got long-term access to antibiotic prescribing data, national data. We monitored that, and what we found was that there was no real change in patterns of prescribing, and actually the quantity prescribed was beginning to increase. We interviewed dentists, and without exception, all dentists said they were very confident they knew what to prescribe and when to prescribe it, but there was huge variation across dentists. They believed that their peers, their colleagues, often prescribed unnecessarily. They never did themselves. And actually, they didn't really have much of a sense of antimicrobial resistance, and certainly didn't think that they contributed towards it. So something needed to be done. Our first initiative in this area was using this data to carry out a national randomized controlled trial of audit and feedback. And what we found was that audit and feedback did reduce antibiotic prescribing rates by 6%, and inclusion of a message that basically reiterated the information in the guidance had the greatest effect. We also carried out a process evaluation to help better understand this and the barriers and facilitators to change. What was hugely frustrating, at the end of this trial, we had a positive impact, but there was absolutely no mechanism for sustained delivery. However, we continued to monitor the data, and actually the downward trend in quantity continued. But we'd also published a national criterion-based audit, which was completed by around a third of all dentists in Scotland. And what we found, there was no real improvement in the when and the what that was actually prescribed. So we thought more needs to be done. And we had some specific objectives. We didn't want to discard all the work that we'd done before, but we also wanted to do something where there was at least some potential for sustained delivery. And things came together quite nicely. There's evidence that outreach or in-practice training can help potentiate the effects of audit and feedback and prescribing. And in Scotland, all dental practice must undergo infection control training every 3 years. And this is delivered by a national team called the Quality Improvement In-Practice Training Team, or the QIP team. This is the QIP team. We had an existing relationship with them, and it was agreed there was potential to incorporate a session on antibiotic prescribing within the infection control training. So our aim was initially just to test the feasibility and the acceptability of doing this. We wanted to build on our previous work. We wanted to have theoretical underpinning, and we used 2 frameworks from the psychology literature, theoretical domains framework and the COM-B model. And we also wanted to precisely specify the active ingredients of behaviour change techniques within the intervention, the training intervention. We knew we couldn't do this ourselves. We had to do it in partnership and collaboration with both the QIP team, but also practitioners who were practicing in practice. And we worked with the Triads collaboration, which is a multidisciplinary collaboration of healthcare professionals and implementation scientists. This is the methods we used. The barriers had been identified before during our previous work. Identifying the active ingredients and how to deliver them, this was very much a collaborative effort. And TIP-TAP was the eventual intervention. This is the intervention, very briefly. We sent prescribing data out to dentists prior to that. There was a presentation to set the scene and prompts for discussion. There was a problem-solving discussion. We also supplied a toolkit with things such as posters, scripts for delayed prescribing, and we initiated action planning at the visit, which was completed by the practice afterwards. That's an example of the audit and feedback, where the red line is the dentist's own prescribing, the blue is the average for the health board of that dentist, and the text at the bottom is the behaviour change message. This is one of the introductory slides, and what this does is it reiterates the consequences of over-prescribing or unnecessarily prescribing. These are the behaviour change techniques, and for example, beside the watch, it's the salience of the consequences if we don't do something now, and the skull and crossbones is really to emphasise this. And this is the poster and the leaflets, and these were kindly, we were allowed to use them from Public Health England. I've made this sound as though it was all quite plain sailing. Actually, it wasn't really. We didn't have a training package. We had to develop that from scratch. The research team, we really didn't have a true understanding of real life in dental practice, and working with the QUIP team and the practitioners, they really, really kept our feet on the ground. In terms of the non-researchers in the team, they felt they lacked understanding of both the subject matter and also the theory underpinning that. And the impact of that was initially they were very hesitant to actually suggest changes to the intervention in case they mess things up. And they wanted to do more self-directed reading, they had some more training and lots of discussion and debate. The data itself was quite problematic. I felt it was really quite straightforward, but others within the team actually didn't really understand it and didn't know how to present it. So we worked with dentists and dental practice to try and actually improve the data. There was concerns very much about dealing with different types of problems, so we thought of all the possible scenarios, developed scripts and rehearsed them. And a lot of concern from the QUIP team, their dental nurses, they didn't know how dentists would actually accept training from them. So we developed scripts to reiterate they weren't telling the dentists what to do or the dental teams what to do. It was to generate discussion. We then, when we had the intervention, we carried out the feasibility and acceptability study. 10 practices were invited to take part, all 10 agreed. It was 113 members of the dental team, 3 of the QUIP trainers. We had 4 questions. Can we deliver it? Is it acceptable to the teams and trainers? And how might it actually be refined? And we did this through questionnaire, interview, and observation. This is some practice feedback. We asked them, did they like it? And the 4s and the 5s, that's the more positive end of the scale, and you can see the majority of did. And they would actually recommend it to others to undertake the training. QUIP team feedback, and this is actually slides that the QUIP team themselves used, from the initial trepidation and, oh, for goodness sake, what on earth have we got ourselves into, to starting to puzzling it out and working through it. And then eventually they said it was like a light bulb had gone on their head. They could do it, and they enjoyed actually doing it. Again, there were challenges. The QUIP team were keen to expand their role. They were very apprehensive about doing this. So it was 3 of the more adventurous trainers who actually agreed to take this forward. We had to set up new administrative processes between the research aspect and the training aspect. There was concern, it's dentists who prescribe antibiotics. So can we actually have a whole team discussion? And the QUIP team by this time felt confident enough to adapt to training to actually allow each professional group to have their say by themselves within the actual training time. Problem-solving discussion was difficult, and we required lots of facilitation, more training in how to facilitate discussion. The actual antibiotic prescribing itself, the charts, dentists didn't really share it, and the team were not confident in initiating discussion about it. And also, if there were wide gaps between the training visits, the confidence they'd built up, the training team, started to dip again. What didn't work? Prescribing charts and discussion. We still have to actually tease this out as to how we can improve this. And also, as I say, the large gaps between the training. What did work? I think the partnership working, we wouldn't have had such a relevant, practical, but also theoretically robust intervention had it not been this joint collaborative partnership working. The dental teams, they seem to really appreciate, enjoy the training and feel it was useful, and actually including all of the dental team was much easier than expected. The toolkit was very welcome received, especially the posters, although in one practice, they actually went to put the poster up and discovered they already had it, but they actually hadn't realized that was the case. So there were a number of suggestions to improve delivery, including developing scenarios, more training in facilitating discussion, and areas such as icebreakers for the data discussion. What next? Well, the TIPTAP team feel that the practices welcome the training, and intuitively they feel that it will improve antibiotic prescribing. And all QUIP trainers are now going out in pairs with an experienced trainer or less experienced trainer to actually deliver this training. However, they're an absolutely brilliant team to work with. And what they also want to do is get robust evidence that there is actually a positive effect of the training. So in the winter of this year, we'll be starting a national randomized controlled trial to actually evaluate the impact of the TIPTAP training. And just very briefly to conclude, I think the lessons that we've certainly learned is that when you're thinking about implementation, our initial rapid trial, I cannot explain how frustrating it was when we could not sustain delivery. So actually, I think there's more of an opportunity and potential for sustained delivery if you try to incorporate your interventions into existing service initiatives. I think it's crucial that research teams, guidance developers, do not try to do this alone. You have got to involve other stakeholders, especially those who are actually working in that context. However, there is a real need to actually very carefully develop and pilot and test acceptability and feasibility of any intervention to support implementation that we're thinking about trying out. And that's really all. I'd just like to end by thanking all of the team who worked with me. I'm a very small part of the team, and the dental practices who participated in this project, and just really any questions. Okay, thank you.
You can wait there.
Okay.